This is a live Channels television event.
That they have been doing. This is amazing. If we've been on the insurance journey for 3 decades, but within a short period of time, we've sort of seen an uptick in enrollments. And yesterday, our president made a decisive statement by approving the implementation of the mandatory health insurance requirement across MDAs and directing us to work with the private sector, because it's not only the public sector, the private sector also needs to come in, but to work with the private sector so that the mandate, as we implement over time, will be one that also doesn't constrain them, because we have to grow the economy, but also provide financial protection. We say in the interest of the private sector to see that a financially protected employee is a protected employee, is a happy employee. And the wider the risk pool, the healthier our population, and they will patronize the businesses. So there's an incredible positive loop in that direction, and we really thank the President for that. Our goal is to get at least 44 million Nigerians covered with health insurance by 2030, which will make Nigeria to have the largest pool of health insured people in this continent, and will be noticed and will change the dynamics of our healthcare market. For our vulnerable populations, we've seen expansion of the Vulnerable Goods Fund, the emergency obstetric services that have been made free and reimbursed by NHIA is saving countless numbers of women from dying due to complications of obstetric care. The fistula care, thousands of women have been covered, repaired, and empowered and integrated back to society. Subsidy mechanisms for kidney, for dialysis, and now in 2025, the Catastrophic Health Insurance Fund to cover catastrophic illnesses like cancers, kidney disease, and spinal surgery, which NHIA is trying to operationalize now, but it's already in the 2025 budget. And amazing partnerships in terms of expanding local manufacturing through PVAC, the Presidential Initiative to Unlock Value Chain. So you will all agree with me that under President Bola Ahmed Tinubu, we have built a strong national foundation and a framework for financing health. But further progress as we go depends on the levels of government. Spending still, which we are working to reduce, to ensure that families bear less of the direct cost, and that the private sector investments, Minister of Budget raised the issue that we needed to do a lot more to crowd in private sector investment so that we can be able to harness those resources. Challenges of data, which is some of the issues that we've discussed here, and use of evidence that is locally, that's grounded in our context. I think that was discussed, on day 2 of this dialogue. Those are some of the things. But we have also learned additional things, that countries advance their health financing transition with rising share of public financing, offsetting the declining share of out-of-pocket spending. And this is done through economic growth, as the Minister of Finance is driving us, rising government revenues, which is beginning to happen, and the prioritization of health by different levels of government. That's what allows countries to increase the public financing and reduce the burden on households. For example, China a few years ago, and I happened to be there, when they took a deliberate decision and are now very well advanced in their health financing transition, with a rising share of public financing that is offsetting a declining share of out-of-pocket spending by households. Because in addition to economic growth and increasing revenue, they prioritize deliberately spending in health. If I recall, $25 billion a year over 5 years, which really catapulted China closer to universal health coverage. So it is a combination of this macro fiscal reforms and prioritization of health that move them closer to universal health coverage. Nigeria's consolidated fiscal position has clearly improved, and Minister of Finance will speak more about that, and is showing results in terms of the surging revenues, and that is benefiting all levels of government. At the level of the Federation, I think my understanding from our colleagues is that the fiscal deficit has shrunk from 5.4% of GDP to 3% of GDP, and Minister of Finance can correct me if that is not accurate. This is a significant improvement, and all of us should really celebrate the President, but also the Minister of Finance and the economic team. Minister Wale Edun, thank you for making the hard decisions. And the huge revenues that we're seeing in 2024, but also 2025 and going forward, because this is just the beginning. The reforms went through a very difficult time, but now we are seeing our revenue to GDP going up to more than 11%. I think this is the first time in many, many years. As revenues improve, obviously, health and other sectors would then be invested upon. And states in particular are also seeing much of the windfall, as a total of 34 states recorded an aggregate surplus. In addition to the FAC increase, states' internally generated revenues also grew by 46%, reaching 2.9 trillion, almost 1% of GDP, while grants and aid tripled, I believe, over the last several months to 0.5% of GDP, further strengthening the state financing. And we also understand there is a policy framework on excise, on tobacco, alcohol, and sugar-sweetened beverages that is being developed. Thus, we have an important opportunity to leverage additional public financing towards health spending using the instrumentality of the health taxes, because you hit two goals. You achieve public health objectives, given the rise in non-communicable diseases. If you reduce tobacco consumption and moderate the SSBs and others and alcohol, I think you have a public health benefit, but you also have a fiscal benefit from finance. So there's a double win in there, but it's a trade-off that will have to be carefully considered, because there are also other aspects which the Minister of Finance is very aware and is trying to manage. I think it is clear, the message to all of us is that we have to collectively own the issue of health financing. And for primary health care in particular, which by policy it's at the state level, the federal contributions through BHCPF, NHIA, and the pool funds that we've mobilized exist to support. But the primary responsibility should be at the states and local governments, and that we urge the states and local government to continue to increase and the health budget, and also release them in line with the compact that we had signed, making health a budget priority, and that all the allocations are released, and to commit to the counterpart funding so that the BHCPF, for instance, the 1% CRF that we have put, the counterpart funding of 25% to be realized, and 15% by local government, that's 40%. That will stretch the BHCPF to even deliver more services, because we've seen that working. 37 million visits in first quarter of 2025, 46 million in the second quarter of 2025, as opposed to less than 10 million visits in 2023 when this administration came in. And that we become more transparent to publish our budgets, our disbursements, our performance matrices over time, and to treat health as a core infrastructure, as important as core infrastructure, because it's about human infrastructure, and also a matter of national security, because health affects economic security and is linked to national security. So if it's treated with that sense of urgency, then the assets that we build, the facilities, the workforce, and the systems, they are economic assets. And DG, Director WHO, said that healthcare is not a cost, it's an investment. Our call to action coming out of this, I think, will be very important, and the NHI will crystallize them, codify them, and will be shared widely. And those commitments will not be just symbolic or rhetorics. and that we acknowledge that every naira that we budget or mobilize and get released for health is also a vote for economic growth, for stability of our country, and for the dignity of our citizens. What is most undignifying? Where is the dignity in someone who is sick, in pain, and not able to access or afford the care that is possible? So if we invest in making sure that those are available, it's also about the dignity of our people. There's nothing to be proud of if, let's say, our population struggles to access the quality care that we know our economy can afford. So I think that is a commitment that we are making by participating in this and all the efforts that we are making together. And together with our development partners, whom we appreciate very much for all the contributions that you have made, but we urge you also to work with us to use and strengthen our national systems, to respect our national priorities. Beyond aid, we urge you to also mobilize your foreign domestic investments into the Nigerian health sector through the instrumentality of our own private sector. That is a model of partnership that will allow us to exit from dependency over time. We have many Nigerians in the diaspora who have joined this discussion over the last 3 days. We urge the Nigerian diaspora to come home or find ways home and use various platforms to engage and channel the incredible FDI that you send, remittances, organize it to support the growth of the sector. Because we know hundreds of millions of dollars, billions in fact, come into our country and our continent from the diaspora. That can be organized better to support growth of critical sectors. Even insurance. Recently we launched a Diaspora Health Hub, where diasporans can pay for health insurance for people at home. So instead of charity or sending money when aunt is sick or uncle is sick, you can pay for their insurance. That brings the diaspora closer home. So even the diaspora, we urge the diaspora to, it's not enough to lament, but there is something that everyone can do. And for NHIA, I think it's clear coming out of this, we also have to look at, beyond the mandatory insurance and the public side, the informal sector, expanding for the vulnerable groups, the private health insurance to accelerate the pace of that. I think that also came out. And for states to establish state health financing scorecards to track the funding commitments and the performance, and we would help that through the sector-wide approach. And for us to strengthen community-led accountability tools. Our health fellows are out there in every local government, and we'll lean on you as well in terms of strengthening the accountability so that the quality of the spending that we make will be on an upward trajectory, because it's not just enough to spend the money, it's to spend it wisely to ensure that leakages and wastages are reduced and that they are on the right things. We also have to institutionalize health technology assessments, and the NHIA has been working on that with the support of many of our partners. The research agenda is key. On Tuesday, we discussed with many of the experts, but that research has to be locally relevant, context adapted, so that we're not translocating questions answered for different contexts to our own country. And that is called to the academia. And there are many of our researchers, Felix, I see you, many, and Professor Takbu. I think you all have to mobilize through the Alliance on Implementation Science to ensure that we continue to learn and adapt and course correct what is working, what is not working, and we can share that as we learn from others. And we must also consider dedicated health investment funds for infrastructure and innovation over time. That may lie on the back of PVAC, and we can work with NSIA to see how that could be enabled, because that can be a vehicle for even our development partners who are shifting from aid to have an investment vehicle, a fund mechanism that will further catalyze the private sector growth. For the public sector, And I am very glad that the Minister of Finance is working on the Federation Fiscal Compact, I understand. I think the Health Sector Renewal Investment Initiative Compact that we signed with all the 36 state governments, I think can be a good input into that. The BHCPF currently allocates 1%, at least 1%. And Senator, that's something that I know is on your table. If that could be increased, I think we can explore whether that can go up, and if that goes up, to channel that on the demand side so that we expand affordability, the insurance. That will change the nature of the healthcare market. Imagine 40, 50 million Nigerians able to afford care without cost. It will provide predictability, it will enhance the private sector growth as well as the public, and allow NHI to buy quality services, reduce, in fact, the rate of increase in commodities, because we can pool purchase, for instance, commodities better, because there's a steady financing stream as well. Medipool can also function in that. For states, I think it's important to urge the states to consider domesticating national health laws. The Commissioner of Finance from Ekiti State yesterday made this point, to domesticate the national health laws, to codify them at the state level. That locks them in so that it's only about implementation consistent with the laws of our respective states. So for instance, the NHA, the National Health Act of 2014, state legislature can domesticate them in their own respective states so that it's seamless in the context of their own and in the context of our own federalism. And the use of the P4R instrument, I think HOPE is a good marker for that, but we need to expand those approaches and potentially including the public finance and the BHCPF so that its rewarding results is linked to incentives for behaviors. And since the Minister of Finance is here, I have to also ask, one of the ideas that was raised here was, can we consider utilizing FAC savings for targeted interventions, such as health, school feeding, and other social protection. And health is social protection. And that could be one way to advance this. And we understood that ecological funds were being deducted as source. So can we explore whether the BHCPF counterpart contributions, because federal government 1% CRF goes to BHCPF, which goes to the states and local governments. But if the state counterparts, 25% and 15% of each of the states is deducted at source, packed at the states, so it's assured that it will be released, that may be one way to stretch the BHCPF even further and expand our abilities to afford vaccines, commodities for HIV, TB, malaria, given the shifting global aid landscape, and to expand the Vulnerable Groups Fund as well. Those are some of the things that I believe were discussed and will be very useful. And importantly, to cycle back on what Minister Bagudu raised, that we have to double down on mobilizing private capital through public-private partnerships, innovative finance, blended financing approaches. We've seen a growth in those efforts in the health sector recently for the oncology initiatives, for running our facilities. There are some investments that are happening in terms of infrastructure in diagnostics, in manufacturing. Medipool, a classic example, co-owned by Murphy and a private actor, which is a market-shaping intervention. We need to do more of that because the health economy is much larger than the budget of the federal government or the states. Those are some of the ideas. But importantly, as we embark on rethinking health financing into the next several decades, suddenly reorienting and rebalancing from disease to health and well-being is important. So health promotion, prevention is much more cost-effective. We cannot dialyze our way out of an upsurge of hypertension and diabetes. Yes, we need to treat cancers, but we also need to consider the drivers of that. The DG NAFDAC was here. I believe things like processed food, sugars, we have to moderate those because they're driving a lot of the increase that we're seeing in hypertension, diabetes, strokes, and cancers. What we eat, but also the other intersectoral things that Dr. Kaberuka mentioned, I think, sanitation, nutrition, housing. In other words, health financing is about financing the health system, the healthcare system, but the health system is also beyond that because in a way there is health in all. It's in all that we do, whether it's education, whether it's water and sanitation, agriculture, it has bearing with health. And so those other spendings are also important. And so we don't bother you, Minister of Finance, to say, okay, only us. I think health is important, but the social sector overall, there are many channels through which you support them. So I want to thank all of you for your contribution, but also for my colleagues for showing up. Thank you very much. Yeah.
Thank you very much, the Coordinating Health Minister, for taking us through all the collaborations that are needed and the actions that are needed to improve health sector dynamics, but most importantly, aligning it with other sectors that are important to move the health of Nigerians forward, ensuring sustainability. As we speak, I've been told that we are live on major Nigerian television stations. I'd like to thank the media for this contribution that shows that health is an imperative beyond what we are doing here today. Is a collective responsibility. Yes, in the last 3 days, we have attempted to reimagine the possibilities of mobilizing and utilizing resources for health. And one area that is so important is legislation. You recall that when the non-for-profit organizations met, the plea was, please, as legislators, commit some of your commitments to your constituency when you go around to health, particularly financing health. Nigerians are saying that they do not want the grinding machine and the wheelbarrows, and you know what I'm talking about. But essentially, those that will build more healthier Nigerians to help to leapfrog our development from where we are today. And it is on this premise that I'd like to invite the Senate chairperson on health, herself a medical practitioner, but most importantly, one who advocates for better well-being for Nigerians. Welcome, distinguished Senator Harry Banigo. Namyo.
Thank you very much, MC. The Coordinated Minister for Health and Social Welfare, the Coordinated Minister for Finance and for the Economy and Minister of Finance, Your Excellencies, WHO Regional Director, and the AU Commissioner for Health, the AU Special Envoy, the Permanent Secretary, Federal Ministry of Health, directors and DGs and executive directors of ministries, departments, and agencies, honorable commissioners of health here present, our partners, civil society organizations, our friends, and our media, distinguished ladies and gentlemen. Indeed, I must tell you I am very delighted and very pleased to be here to give you some remarks on this very important national dialogue on health financing and to say that I want to sincerely congratulate the Honorable Minister, the Coordinating Minister for Health and Social Welfare, and all of his team for putting together this health financing dialogue and for attracting such diverse and very key participation towards this dialogue. I want to say that this could not have come at a more appropriate time. It is key in the journey Nigeria is having presently to try and achieve improvements in healthcare and to reverse the dependence on impoverishing out-of-pocket health expenditure. I want to thank His Excellency, our President, President Ahmed Tinubu, GCFR, who has led this right from the word go in December 2023, when he supervised the compact. I thought that was the beginning of actually releasing domestic resources and mobilizing domestic resources towards health. And I can see that played out today, as we've heard remarks coming from the states, from the subnationals, and also in the past 3 days, we've had remarks coming from further down the line of different levels of service in the country. In 2023, when I started my role as chair of the Joint Health Committees of the 10th National Assembly, we came up with a theme, improving stewardship and accountability for universal health coverage. We outlined a 4-point agenda as follows: to enact or strengthen enabling laws that support the country's progress towards universal health coverage, to support lawful measures aimed at mobilizing and sustaining human, financial, and material resources for health through public systems, as well as partnerships with private sector and development organizations, and to promote accountability by ensuring effective public finance management systems in the health sector. And of course, to drive a learning agenda to strengthen legislation, appropriation, and oversight functions across health committees, both at national and subnational levels. Indeed, our agenda did foreshadow today's dialogue and has signaled our intention to support all efforts to ensure that public funds are mobilized, allocated, managed, and utilized efficiently. And so I am indeed very pleased to be here, and I am here really because I believe that this course that we are taking is the way we should go, reimagining the future of health financing in Nigeria and beyond. And I want to consider myself, you to consider me, as an ally in this quest to achieve this great vision. In February 2025, we had His Excellency approved, His Excellency our President approved additional funds of 4.8 billion naira, which was appropriated and allocated for HIV treatments. This significant addition to the 2025 overall health budget was a commitment to domestic financing and sustainability. Now, permit me to highlight some of the efforts we have also taken in legislation and to further help change the health financing narrative in Nigeria. And because I believe that the most important step to take is always to demonstrate commitment by showing personal examples, recognizing that constituency funds belong to the Nigerian people and that health is a priority. I requested that funds from the Zonal Intervention Project for my senatorial district, which is Rivers West Senatorial District, be released to the National Health Insurance Authority for the provision for the provision of health insurance to households across the zone, particularly to vulnerable groups, for children, pregnant women, the elderly, internally displaced persons, retirees, and those people who are in the vulnerable group. And so far, over 6,000 persons are covered through the gift ship run by the NHIA, and I have asked that their coverage should be renewed for a second year, and I intend it to go on for as long as I am a senator of that district. I have taken steps along with the relevant stakeholders to push for a review of the National Health Act to ensure the incorporation of necessary provisions that enable the achievement of universal health coverage and health security, especially demanding an increase in the percentage allocation for the Basic Health Care Provision Fund. We have submitted a bill towards that, and also included in that is to secure immunization financing. I have continued to demand that all stakeholders should be carried along to ensure that this succeeds. We ensure that beyond appropriation, the vulnerable group fund, which had been established by law but was never appropriated, did have appropriation for the first time in the budget of 2024. And it was used to provide free treatment and repair of obstetric fistula in several of our hospitals across Nigeria. We will do all that we can to continue to monitor its expansion and its utilization. We have driven the agenda for the establishment of a catastrophic fund to support people prone to catastrophic outcomes based on health conditions such as renal failure and cancers. Legislators carry out oversight functions on ministries, departments, and agencies in order to ensure accountability. And so our oversight functions over our 33 teaching hospitals across the country, over 44 federal medical centers across the country, over 12 regulatory bodies across the country, and to ensure accountability, my team and I have developed a robust mechanism for legislative oversight. We begin each process by meticulously studying an agency's budget and actions across a 3-year period, and this detailed analysis allows us to enter every oversight visit fully informed and prepared to drive tangible, results-oriented change. For the mobilization of human resources, we also appropriated and allocated funds to improve capacity of our medical schools and schools for training different levels of medical health workers, and also postgraduate training colleges, to allow them, to give them the capacity to be able to increase the numbers of their intakes and eventually to also increase outputs. And so looking forward, as we reimagine the future of health financing, we believe that we need to do more to push for legislation that leverages ongoing tax reforms, to advance the prioritization for health financing. And we need to take steps to also encourage you so that you join us in this technical work, so that we have robust evidence to be able to provide the legislation, the framework needed for legislation, to push for the provision of health taxes that will increase and benefit not only our revenues, but also be a way to mitigate the outbreaks we're getting of not so much of non-communicable diseases. We would also like to see that more steps are taken to use technology to create transparent systems for tracking health data. For tracking health data, we need to see that, for instance, we need to improve the capacity to use data for decision making and for planning. In September 2024, I was part of the launching of the Stillbirths dashboard in collaboration with IHVN and the Federal Ministry of Health and Social Welfare, which provides real-time insights on occurrence of stillbirths, aiming to reduce preventable stillbirths using the dashboard as a tool for taking informed decisions. We need to use more technology to create transparent systems for tracking health funds as well, from the point of allocation to disbursement, so that the money gets to do what it's actually meant to do, and eventually to improve on our overall health outcomes. Last year, we held a legislative summit for the health committees at the national and subnational levels. This year, the summit will focus more on engaging state legislators to improve lawmaking and oversight for health and health financing at the subnational level. We would like you to work with us to translate the outcome of this dialogue to actionable steps that can be communicated during the next legislative summit, which will be coming up later this year. And so we recognize that this is a partnership between governments and the private sector. And we welcome all the private sector participants that are on this dialogue. And we want to, as legislative body, we support all such efforts on the private sector with our legislative instruments. We enjoin the civil society organizations and the media, our friends, to continue with their role of building trust within the system. Universal health coverage is a journey, and it requires that we all have the discipline to communicate what is helpful to Nigerians. And so, in conclusion, the health of our nation is our true wealth. The health of our nation is its true wealth. Investing in a robust nation, the health of our nation is our true wealth. The health of our nation is its true wealth. Investing in a robust healthcare system is not an expense. It is an investment in our productivity, in our economy, and in our future. We believe that with a reimagined approach to financing, we have the collective will to make the change. And I hope that this dialogue will be the start of a new chapter where every Nigerian can access
Well, leadership by example. I think she deserves a very, very loud round of applause. It is workable, the collaboration across quarters. It is also gratifying to note that she has devoted her constituency allowance to ensuring better health for Nigerians in her constituency. I hope that my colleagues will make this loud so that other distinguished members of the National Assembly, the state assemblies, and cascade good health to all Nigerians without having to worry about out-of-pocket expenditure. We're moving on. You would recall that during the course of this event, we have with us the man who holds the purse. And he's nodding very happily to me, so I can say it. And we hope that the purse today will open further and wider. Is it an agreement? Is it a consensus in this house, in this room? All right? So we have that consensus, and it's on that that I want to invite the coordinating Minister of Finance, Mr. Wale Edu, to please speak to us as he opens the purse wider.
Thank you and good afternoon. Let me first of all recognize someone who was with us virtually earlier, Governor Charles Soludo, Governor of Anambra State. My colleague, my friend, my brother, the Honorable Minister for Health and Coordinating Minister of Social Welfare, Professor Mohammed Ali Pate, the Chair, Senate Committee on Health, Dr. Harry Panigo. At this point, let me say welcome to the AU Commissioner for Health, and of course, Permanent Secretary Health, the heads of agencies, civil society, our development partners, all those who are helping us with the health agenda in Nigeria. Gentlemen of the press, distinguished ladies and gentlemen, it is for me an absolute pleasure to participate once again in one of the many initiatives, projects, and platforms, fora, that our very able, very cerebral, and much celebrated Honorable Minister for Health and Coordinating Minister of Social Welfare has put together. And I really mean that. He's naturally tried to stretch the finances of Nigeria by trying to attract as much as possible to the health sector, but not only. I mean, look at this hall today. This is the fourth day of a dialogue. And it is the afternoon. The place is packed to the limit, every seat taken. And it's a sign of the capacity of Professor Mohammed Ali Pate to bring together, to convene top elements in the health sector to forward the agenda of health in Nigeria. Today, we are talking about health financing. But you know, I've been all over Nigeria with him, opening radiology and diagnostic centers in Bauchi, opening oncology centers in Katsina, Enugu, Edo. He's everywhere. And he's implementing a major mandate in terms of the social and health reform agenda of President Bola Ahmed Tinubu. More grease to your elbows, sir. Please keep it up. This national financing policy dialogue, and he has encapsulated it. Financing for health is about a growing economy that gives you financing, that gives people jobs, that gives them incomes. It is about government having increased revenues to put into the health sector. And of course, it is about being able to crowd in the private sector where the real money is. We know that Mr. Bill Gates, the philanthropist, as we recognize him now, says that it's where the public sector and the private sector leave a gap that philanthropy comes in. So definitely, of course, that philanthropy sector is also critical and important for financing of the health sector. But this dialogue is critical. Of course, that philanthropy sector is also critical and important for financing of the health sector. But this dialogue is critical, urgently required, is in alignment, as I said earlier, with the reform agenda of President Bola Ahmed Tinubu and his pursuit of inclusive growth. You all know, we don't need to repeat, that health is wealth and how critical that is to the economy. But it is a reflection that our success in healthcare requires a coordinated system that mobilizes, pools, and allocates financial resources to ensure that we have equitable access to health for our population and the required investment in medical services. We've heard the breakthrough in terms of health insurance so that people don't have to put their hand in their pocket every time they need health care. That, as we all know, is not the way. And wherever you are in the world, when you need health care, it is much more accessible if it has been pre-planned, prepaid for, or you have an easier way of paying for it than having to pay on the spot. That is most difficult anywhere in the world. And that's why rebuilding the economy fit for our people's ambitions is what is going on at the moment. Important, bold fiscal steps continue to be made to restore stability and make sure that the gains from the economic recovery are felt where it matters most, in the clinics, in the community, and of course, in the households. We've heard about, and I'm sure you're all aware of the improvements in healthcare at the primary healthcare level. More practitioners being trained, better management of healthcare at that all-important level. But let's look at the context in which we are talking about financing of healthcare. Apart from addressing decades-old macroeconomic distortions, and we all know what they are, and then creating a stable macroeconomic environment where private investment can thrive, where it can come in at scale across all sectors. We now have a situation where there's an attempt to build government savings so that will enable investment, public investment in assets, in critical sectors, infrastructure, health, education. And by doing this, government becomes a catalyst for the private sector. It was said earlier, and I'm sure it will be repeated, the private sector is critical in financing of health facilities, provision of health care throughout the country, just like in other sectors. And over the past 2 years, the bold reforms, yes, they have come at some cost as you repair and you fix some of the things that were broken in the economy. So the removal of subsidy was a decision that was tough, but it has restored fiscal balance, not just at the federal level. The states, they have much more money. They have double the kind of funds they had before, and so they are able to provide their own contribution in this all-important area and others. And let me here address something that Professor Pate remarked on, and that was a source of funding that brings together federal, state, and local governments, and that's the federation account. And I think any initiative there, any ideas or suggestions, the rightful place for that discussion is within the National Economic Council and the Federation Account Allocation Committee. That's where such ideas and proposals should be presented and can be meaningfully discussed, and hopefully with success in terms of coming up with viable ways of financing healthcare in addition to everything we have mentioned. In addition, just to give us a sense of how we are moving forward and getting the funds that are necessary for this critical, for funding of this critical area, which there's nowhere in the world where, without a viable public health system, social welfare system, you can say that you have a caring, a modern, and a progressive economy and society. So we have signed into law comprehensive tax reforms, simplifying compliance, reducing nuisance taxes, and strengthening the administration. And we are driving structural reforms in energy, education, logistics, such as the CNG initiative. And importantly, we continue to build, using digitization, automation, and technology, a social safety net that is getting more and more robust, that allows intervention directly to people who need it in a form of financing. And these reforms, they're all meant to build a competitive economy, an efficient economy, and as I keep repeating, one where private investment, whether local, domestic investors or international investors, where they can thrive. In terms of healthcare, of course, when you remove a distortion such as a subsidy which was only benefiting a few and even benefiting foreigners, and it was gulping about 2.5% of GDP. When you remove that, the opportunity cost was that there wasn't enough funds for investment in healthcare, education, and so forth. Therefore, it will take time, and it is taking time, to recover the kind of investments that have been lacking over the years. And that's why Professor Pate is in such a hurry to open up so many healthcare centers, radiology centers, oncology centers. And we must remember there's a financial, economic imperative to this. The more of those facilities that you have in Nigeria, the less people not only need to spend hard-earned foreign exchange and time and expense to go abroad for. In fact, you have the reverse. You now have facilities with which you can attract foreign exchange. You are exporting your services by people coming in and using those services and paying foreign exchange, and allowing economies of scale and full utilization of such facilities, even though we know they are primarily for Nigerians. So we now have 4 elements to our growing economic stability. The external reserves position is strong. The fiscal position has meant the elimination of routine use of ways and means, printing of money. The economy is growing at about 3.4% last year. Well, when you have growth, you have job creation, and you have elimination of poverty, reduction of poverty, which is the overall aim of His Excellency, Mr. President. But not at 3 or 4%. We're looking to, within the next couple of years, 7% per annum growth, because that will be more than double population growth, and that is when you start lifting Nigerians in their millions, in substantial numbers, out of poverty. That's the aim. Of course, inflation is moderating. It's about 4 months now. For about 4 months, inflation has been going down. May I say, more importantly, as at July 1, I did join the Honorable Minister of Health and Coordinating Minister of Social Welfare, as I said, to open up, establish, and launch oncology centers in the northwest and the southeast of Nigeria. And the important thing is that without the reforms that have taken place, these investments, the establishment of these facilities would not have been possible. So there's a direct correlation and link between correcting distortions in the economy, having the economy grow, and putting more facilities on the ground in the health sector. Let me mention that today, private spending on healthcare in the private spending accounts for 74%, as we said earlier, 74% of health expenditure, while the public and donors account for about 14.4% and 11.6% respectively. What I think I'd like to emphasize about our ability to spend on healthcare is that it has been greatly impacted with the changes in the global economy and world order, I may say, particularly in WHO, World Health Organization, which lost about 40% of its funding, as we all know. It impacted Nigeria. I think we were getting about $800 million a year in support for various initiatives in tuberculosis, malaria, and so forth. But our ever proactive Minister of Health, immediately that announcement was made, went to work with his team, and he found that through careful calibration, we could use a much lower sum to replace what had been lost. There were savings that could be made from smarter purchasing and so on and so forth. And so immediately came back with a much lower budget to ensure that we Nigerians did not suffer as a result of the fact that something that had come to rely on was no longer there. We reacted immediately and filled the gap, and we're grateful for him for that. Of course, as we heard, the President has taken the lead in directing the implementation of mandatory health insurance across all MDAs. It's a very notable, very laudable, and critical initiative, because, as we had said earlier, it's so difficult when falling ill on the spur of the moment to just find the money from the normal budget. So insurance is critical in giving Nigerians access to the health care they need when they need it. So now we must follow the President's lead. If there's insurance, there must be enforcement. And I think this dialogue is a great start. And I have no doubt that the scale and detail of this dialogue can only mean robust, actionable, implementable policy proposals that will make our healthcare investments not just possible, not just larger, but also sustainable. The whole important thing about so many policies and initiatives is, one, to implement them, but then two, to be able to sustain them over time so that you grow and develop them rather than have them recede. Scheme. And as we said, the states, as Professor Soludo even indicated, that the states need to also play their role to protect the poorest with premium subsidies and to enforce one-time payments with short-term claims. So essentially, let me say that things like, as Dr. Banigo also mentioned, data, published scoreboards. And we know that when households are protected, they seek care earlier. And the providers of that health gain steadier cash flows, and the system becomes investable. You need a system that works, a system where the premiums are paid, claims are paid, and the whole system is funded in a way that is sustainable. So I think we all collectively have need to coordinate to ensure that this important health insurance initiative works, and it works well. It is key to sustainable financing of the health sector. Macroeconomic stability is also a health policy by other means. But it only counts if it changes the experience at the primary healthcare center. Budgets do ignite the effort. Insurance and investment scales it. And today's directive on health insurance helps ensure coverage is not just is not optional. Coverage will not be optional, and it is operational. And we need to stay the course. We need to be disciplined, data-driven. We need to collaborate. We want the clinic at the corner to become the first stop, not the last bus stop. Oh. Thank you very much indeed.
Thank you. We need to collaborate. We need to also ensure the operations of the primary health care. Most importantly, we need to take health financing seriously to reduce the burden of health care. We are moving on. I'm going to call on one of the gentlemen that have been assisting and part of the LOC. I'd like to invite Dr. Zuba, who would lead us into the next few sessions, and then we'll come back. At this moment, I'd also like to refresh us that we are live on Nigerian Television Authority as well as Channels Television. You have the microphone.
Honorable Ministers, Permanent Secretary, distinguished guests, ladies and gentlemen, we've listened to very interesting interventions from the Minister of Budget and Economic Planning, Minister of Finance, Minister of Health. We now want to convene a panel where we would then listen to contributions from our distinguished guests and also take questions from the audience who have been itching to ask questions to the policymakers. And I would just very quickly invite to the stage. I would invite members of the panel to the stage, and okay, so as the Honorable Minister of Finance and Coordinating Minister of Economy takes his leave, I would just invite to the stage distinguished Senator Ipalibo Banigo, the Chairman, House Committee on Health, Secondary and Tertiary, to Senate Committee, to please come to the stage. I would also invite the WHO Regional Director, Professor Mohammed Yakub Janabi, to also join her on stage. This panel will also be joined by the Coordinating Minister for Health and Social Welfare. As soon as he returns into the hall, he would join the panel as well. Together, we would be listening to diverse opinions from translating legislation, budgets, and policy into action towards universal health coverage. And you're welcome back, Honorable Minister. Thank you, Honorable Minister. The Honorable Minister has to make sure that we secure the bag. Thank you, Honorable Minister. I would just invite Dr. Donald Kaberuka, AU Special Envoy, to mobilize international economic support for continental fight against COVID-19, to please join Honorable Minister and distinguished Senator on the stage, sir. We would await the Regional Director for WHO Afro to also join the panel, but I would just immediately invite the moderator for this session, Oluyomi Akinyemi, from the KPMG, to take over proceedings and engage the panelists. So Yomi is going to be taking questions from the audience and would also throw questions, his own questions, to this panel. We've had very interesting conversations in the past 4 days now, and we'll just look to a very engaging session and dive deeper into insights of the comments that we have heard during plenary. Yomi, please.
Good afternoon, everyone. My name is Yomi Akinyemi, and I'm a partner with KPMG. We've been, it's normal to start sessions like this with standing on established protocols, but as this is our first fireside chat, and I'm also seated on this side, with the Coordinating Minister of Health and Social Welfare, we also heard the coordinating minister for the economy and the minister of finance, having an important conversation around health financing. But because we are seated, I think it's appropriate that rather than standing, let me sit on established protocols. I don't take lightly the importance of this conversation. All week long, we've been having conversations around health financing, and it brings in one room two coordinating ministers to talk about health financing, being at the intersect, of what the conversation is about. So it's indeed my pleasure and a privilege to moderate this session. I'll start with a few questions, and then of course I'll open, I'll open it up to the audience and those online to also participate in the dialogue that we're having today and that we've been having all week long. So I recognize our panelists, Professor Pate. I also recognize the Senate Chair on Health for Secondary and Tertiary, Dr. Harry Banigo. I also recognize Dr. Donald Kaberuka. Thank you for visiting. So I'll start with a few questions. And my first question will be addressed to Professor Pate. We'll be discussing innovative domestic financing. Several months ago, and it continues till date, we've seen a declining source of donor funding. So what are your thoughts as to the options we have to drive innovative domestic financing, especially as we are looking at health financing, the role of public-private partnerships, the role of sin taxes, and the opportunities around these diverse opportunities?
Thank you. I think the last 20, 25 years have been the golden era of global health and global financing. Before then, we didn't have many of the instruments that we have currently, the Global Fund, Gavi. Many of the instruments that support countries were not in existence before 2000. Since their establishment, we've seen dramatic increase in resourcing of health, which is because of the global solidarity and the contribution of taxpayers from all over the world to key challenges, HIV, TB, malaria, vaccination. And I think we have some results to show for it. But we also know that even before COVID, the pace of progress was slowing down, and things like financial protection were going in the wrong direction. And more than half the world's population, and in Africa, more than half the population, lacked access to basic quality health services. And COVID exposed further flaws. And since COVID, many things have unfolded, and shifts in politics, nationalism, weakening of global solidarity. I think it pushes the global health entities and challenges them, especially given the multiple competing priorities from those who are funding them. So for us in countries like Nigeria, while we appreciate all the contributions of the past, the changes in the last 8 months are a wake-up call, I will say an opportunity to face the reality that we cannot hope to build a healthy society for our people on the back of somebody else's money. That we have to find ways to take ownership, to use the resources that are currently on the table, but to be on a path where we exit the paradigm of dependency that was beginning to settle in. And by doing so, be more efficient in deploying our resources, the quality of our spending, and look to where we can mobilize additional resources domestically, as we have heard from Minister of Finance, and those mechanisms that will allow us to control the priorities, industrialize, produce some of the things that we have. Many of the items that we were receiving from the global health assistance were commodities, but they are not produced here. We should be looking beyond that, where the things that we can produce, there's an economic value also that we can create, even while addressing the consumption needs or the inputs that are needed to deliver quality health services. So we see this as an opportunity, really, a moment of reset, while appreciating the past, but looking forward to a different kind of relationship with our partners from the wealthier countries, but also from within our continent. Because at least in the context of Africa, we are close, we share many things in common, and we share many things with other developing countries. But within that context, in a respectful manner, not in a positioning of a supplicant, but where we take responsibility and we step up while our partners support us to achieve common objectives linked to our humanity, and when issues arise, that we deal with them together. That's what Nigeria has tried to do. The sector-wide approach prepared us very well, and as you have heard, the political will was there from the president and other members of his team, and I think we are on that path, and the discussions here today are just refining or making it more evident the options ahead of us to move in that direction, whereby we increasingly efficiently mobilize our domestic resources. If we reduce out-of-pocket spend, expand the risk pool through insurance, where just by doing that, bringing in more ability to pay for our healthcare domestically. And the progress that we have seen, in fact, has been financed domestically to a large extent, but it was just inefficiently financed. So if we organize it better, we can purchase better, and our people will get the help that they need. And a last point is, because the supranational priorities dictated where we are going for a long time, and while we have results to show for it, if we don't have enough resources, then we have to rebalance the imperative from a primarily disease-focused one to one that balances the disease-focused effort with the health production side as well. So preventing NCDs, dealing with food systems, processed foods, for instance, trans fats, salt, sugar, and other things, vaccination, water and sanitation. So health in all approach rather than just public health by itself. Do you get me? So there's a need for that, because that's stretching public financing to deliver a lot of value in terms of health outcomes for our population. What health can do and what sectors other than health, the social determinants, can also do. And I think that's why it's so important to have finance ministers, budget ministers, and other ministers in our team really tune into this as part of this adjustment to the reality that we have, not just about the diseases.
Thank you. As you spoke, it was clear to me that the significance of the task ahead of us is quite extensive. My next question will be to Dr. Harry Banigo. It's really to speak to how do we, in your words, the minister, drive ownership? How do we drive ownership at the subnational levels? State and local governments, and looking at it from an executive and legislative agenda. What are your thoughts in terms of how we can work with the states better to actually drive the agenda on an overall basis?
Thank you very much. I think this is a good opportunity for us. We are actually always looking at the unending supply, always thinking of the supply there. We're now really coming to look at the real issues. And that is why our Legislative Health Summit, which we held one last year, we're holding another one this year. We are conscious of the fact that we need to have a learning agenda across the subnationals. And when we bring the chairman of the health committees of the various states houses of assembly. We, all 36 of them, attend this health summit. They come with the secretary of the Committee of Health. They come with the chairman of the Appropriation Committee and also the speakers of the different houses of assembly. And it is an opportunity for us to share information across one another. And in some areas, what has worked, and they can share that kind of information. And so that kind of learning agenda enables collaboration and coordination of activities across health to improve health outcomes. Because everyone is interested in seeing how we can improve on the health outcomes that we have. When we are not happy when we see Nigeria being given, having the highest maternal mortality rates, child death rates, neonatal death rates. And so some states will have examples where what they have done in their states, maybe the way they have used data, maybe the way they have used community development committees at the primary healthcare centers, how they have supported them, giving them capacity so that they can actually see what is the progress of their primary health centers, take ownership of the primary health centers, and be able to say, look, there's no water here. What can we do to provide water? Or there's no light. What can we do? Can we bring in solar plants to ensure? Can you imagine a health center that has no light, that is dark? Which patient or client would like to attend that kind of health center? Or a health center that has no running water? It just doesn't make for sanitation. It doesn't encourage a clientele, a patient, to approach such areas. So it is important for us to be able to continue to drive this type of this platform where we can exchange ideas of what has worked in each state, in each local government. And then others can also learn from it. And others can also bring their own thoughts about how it should be. For instance, I can tell you that some people believe that we could make better use of just making health information available on simple mobile devices, very simple ones, that can help people to know, look, if you have frequent stools, don't do this and so on. You know, our mothers in the villages, they all have these very simple phones that they use maybe to receive small sums of money from their children in the cities, 5,000 naira, whatever. And we could also use this, leveraging networks, data networks and so on, to provide simple but targeted health information. And that also came up and was discussed, and some communities are using it. So we need to strengthen our village development health committee, our primary healthcare development committees. We need to strengthen them. We need to let them know that this thing is all about them, so that when the health center is in their community, they can actually take ownership of it because they are participating in it. And it doesn't take much to encourage them. I recall that when I was a deputy governor in Rivers State, I was chairman of the task force on primary health care and immunization. And we had some of our partners used to help us to develop and encourage participation of these primary health care centers across all the primary health care centers in the state. And that way, you found them that they really valued the health centers, and they were eager to see that they actually work, and that the communities attend them, instead of going elsewhere where they are attended by unskilled attendants. And that, again, increases shoots up the negative health outcomes in our communities. So these are the things that we can do, and I believe that sharing learning agenda in this way does do a lot to improve our general outcomes on health. Thank you very much.
Thank you. When you spoke earlier, there was a lot of passion in you discussing the personal and collective initiatives you are championing around health financing in the Senate. I would like to extend this question on the back of that, and this question will be going to Professor Janabi, the WHO Regional Director. Focusing on the poor and the vulnerable, what are your thoughts around improving on equity financing to support those disadvantaged groups on a general basis?
Yeah, thank you very much for that important question. I think I'll try to pick up from where Professor Pate touched a bit of it. Towards the end of January, everybody knows what happened. Without caution, without being transitional time, no honeymoon. One of our largest donors in WHO pull up the finances, and the consequences follow up by the ODA reduction of, sorry. Can you hear me now better? Thank you. It's lunchtime, maybe the sugar is going down there. So what I was saying, let me pick up where Professor Pate started. The beginning of this year, we saw the financial reduction to WHO. One of our biggest donors pulled out. The ODA funding went down. And it's a time when I was in my campaign for the position which I am today. So among the questions which I asked myself, how is the financing in WHO? So you have the assessed contribution and you have voluntary contribution. Our assessed contribution was up to 20% and sometimes less than 20%. The voluntary contribution is 80% up. So one of the questions I was asking myself, do we really own WHO? Because if it was a business entity, you are the minority shareholder. So to fast forward, the member states, I'm very grateful with also the initiatives, the assessed contribution, all the member states have agreed to increase it, hopefully, and wishful by 2030, at least we should reach to the 50%. And the initiatives you are seeing today of member states trying to take ownership of their health, this is the only way we can reach those most vulnerable. Because coming back to Afro, where we have 47 member states, the priorities of Nigeria can differ from priorities of Burundi. Priorities of Burundi can differ from priorities of Cameroon. So the question we as WHO Afro, how can we reach the most vulnerable? These are the measures which I'm here in Nigeria, a living example of the initiatives which Nigeria is taking. One of them endorsed by His Excellency, President, is universal health coverage. Let me remind the audience, COVID-19 exposed us how fragmented, how weak our health systems are. And I wish we had learned from some of the lessons from COVID-19. I will cite one simple example. During COVID-19, I was leading one of the hospitals in Tanzania, our national hospital. We saw the trends of diarrhea diseases going down. We saw the trends of respiratory diseases going down. Do you know why? Simple measures were taken. People are using sanitizers, washing their hands, wearing masks. These are simple measures which brought down everything else apart from the COVID, which was the main disease. Today, we are in Nigeria. Let's talk of Nigeria. The target is to get 120,000 community health workers. Outbreaks starts in the communities and end up in the communities. If we invest on these community health workers, if they pick the signs and symptoms of basic diseases right from the beginning, it will prevent the need of tertiary services. And I will cite a simple example for the time's sake. You have two types of diabetes. Type 1, which is insulin dependent, and type 2, non-insulin dependent. Before you get full-blown type 2 diabetes, you pass through a process which takes about 10 years, from insulin resistance to pre-diabetes. Now, these 10 years, if we integrate the NCDs to the primary health, I can pick high blood sugar. High blood sugar and diabetes, these are two different things. What will I do? Just change your lifestyle. Pick what you eat. So I think for me, and I can say for WHO, the primary health care is a backbone for our continent. And I think if we invest properly, spend smartly, as it was narrated here, multi-sectorial, because today, if there's an outbreak of cholera in Kaduma, everybody looks on Professor Pate, but it's a multi-sectorial. There's a sanitation, so there's a Minister of Waters, a Minister of Lands, and let me finish by one last example. Why multi-sectorial here is very crucial. If you look on our outbreaks in the continent, which last year was 109, they are zoonotic in origin. They are coming from the animals. So when we do surveillance, we should expand it. We do surveillance on humans. What about the animals? What about the forests? Okay. So, Mr. Moderator, let me just finish here by really, as I said earlier, what we are doing today in Nigeria, if it's successful, and I believe it will, with what I observed today in the hall, can be replicated elsewhere. And it's high time for our member states in Africa, the 47. I'm just coming from Lusaka. The maternal mortality rate is 85 per 100,000 live birth. So what, let's say, Nigeria can learn from Lusaka, from Zambia?
All right, thank you. Thank you. Thank you very much. You know, you spoke extensively and you've almost exhausted all my questions, but I still have a few more. And I would like to go to Dr. Donald now. Dr. Donald, you know, we recognize your extensive experience in the finance sector, in development finance institutions, and we want to tap a bit from that. You know, what do you consider to be the safeguards and good practices based on your extensive experience that we as a country should consider ensuring accountability and transparency, but more importantly, to the purpose, to the end of attracting capital, more capital for health financing? What are your thoughts on that?
Thank you. Let me sure I understand the question. It's about attracting capital to Nigeria or into...
Yes, it's about driving accountability and transparency, the best practices in this area that help to give comfort to potential financiers, and they're able to bring in more capital for health financing.
I don't know if I have an answer for that. Maybe Mohammed should You should be the one answering that. So, are you sure I'm the right target?
No, you know.
I want to pass this on to him.
Okay. So, please, does any of Mr. Mohammed or Professor Pate, do you want to help?
Okay. I think I've always said when I grow up, I'm going to be like him. So I want to be like him. I think at the end of the day, resources, whether they are government resources or supranational resources, bilateral resources, multilateral financing, it comes from somewhere. Somebody generates it. And it starts with the taxpayer of the countries, whether it's a Nigerian taxpayer or developed country taxpayers that contribute, whether it's a Global Fund, Gavi, World Bank, or whatever it is, the taxpayers appropriate resources that end up in the global pools. Whether it's our domestic financing that Senator Banigo allows us to have, it's Nigeria's taxpayers' money. So those taxpayers have an expectation that those resources will be used and used well. And those of us that are, let's say, the duty bearers to deliver for the principles of those resources have to ensure prudent use of those. And there are many inefficiencies that are possible. So when you allocate resources in a health system to only the big hospitals, only the urban centers, and everybody that has malaria goes to National Hospital, for instance, to get treated, it's much more expensive. Those could be treated at the primary healthcare level. So by allocating inefficiently, you are wasting resources that are public resources. You could stretch those resources by allocating them where they need be. If you allocate resources that are spent only when people are most severely ill, versus when you go on prevention, you can prevent measles by immunizing children. So you immunize them with a few dollars of vaccines, thanks to Gavi and others. Then you prevent those children from getting diseases that ultimately will cost a lot more to be taken care of. So by doing that, you're efficiently using the taxpayer money or the international taxpayer money. So showing that improvement in allocating efficiency is one. But tracking the resources when they are released, whether it's budgetary resources. So in the context of Nigeria, be it CPF, I think there's a good example there. When we disburse funds, direct facility financing, we had an audit. We looked at it over the last several years, and they are imperfect, what is happening at the facilities. We had an action plan by all the states signing up the corrective measures, and when we disburse the resources for BHCPF, for the last seven disbursements in the last 2 years, we do it openly. The media is there. I think Rachel and many others from the media are always there to listen to the dialogue, to listen to the approval, and we also encourage our anti-corruption bodies, ICPC, to track, because it's not just what happens here in Abuja, but when it goes to the facility, is the person in charge aware that those resources are meant to be used for a particular purpose, and so that there are no misuse of those resources, to minimize that. Because sometimes folks may spend the money, but they may not be able to account to it or report it as they should. It's not that they've taken the money away, but they just cannot account for it properly. But to also match it with building the capacities. Finally, using tools of social accountability. We mentioned the National Health Fellows, and there are also other tools that we're using to ensure there's independent monitoring of the resources, the resource flows. There are many mechanisms that the government is putting in place, and I'm sure our global health partners, whether it's Global Fund, Gavi, they have their own ways of ensuring that the institutions, but we cannot pretend perfection. But we have to work on those institutions so that they continue to move from strength to strength. And we tell our development partners in the sector-wide approach that you use our national systems, even if they are weak, use them so that you can improve them. But if you bypass them and create a separate budget somewhere, a separate project somewhere outside government, essentially you are allowing government to waste its resources just so that you protect yours. But why don't you come closer to government
and influence how government also raises the standards. So with the sector-wide approach, at least we're beginning to move in that direction. Over time, a few years from now, there should be no project unit, program unit, or delivery unit. No, it should just go to the ministries, but those systems have to be there to ensure that they're properly used. So we're developing those systems as well. Thank you.
Thank you.
So the reason I wanted to pass this on to Muhammad is not that I didn't want to answer your question. I just want to make a point that the health of our people is not about money from outside. It's money from us. And I think Muhammad has done a very good job to explain how the little money from outside can be deployed. So let me answer your question just now, talk about our own money, not foreign taxpayers' money. And I think there are some simple rules we can apply in our countries, and I think we can get it right. Number one, let us ensure that our taxation system is based on from each one according to their means. So Nigeria's tax to GDP ratio, as you heard this morning, has been quite low. Still is very low. At 11, 12% of GDP, that is 3 points lower than the average of countries in sub-Saharan Africa. So it means that there are some Nigerians who are not paying taxes. So the first thing is to say every Nigerian, every African should contribute according to their means. It's so important, instead of focusing on money from foreigners, which was your question. But number two, often when we fail to collect money locally, we resort to borrowing. There's nothing wrong with borrowing, but it should be responsible borrowing, bearing in mind our capacity to service the debt. So that would be my second point. The third point is that once you have collected the money from your taxpayers, or you have borrowed, hopefully responsibly, you should then be able to deliver services, of which for me, health and education and security are the three pillars of development. And in terms of health delivery, I know Muhammad agrees with me on this. There are what are called the 4 A's. Please, you can quote me on this, there's no problem. The 4 A's as we deliver services. The first A is availability. The services should be available. That is the number A1. Number A2, they should be accessible. Because sometimes things are available, they are not accessible. There are many countries who announce you are going to have free education, free health services. That is okay. But then they are not accessible. When you go to hospital, there are no books, there are no teachers. When you go to hospital, there are no medicine, there are no doctors. You have been told they are free, so they are available. But they are not accessible. So that is second A. Availability, accessibility. And number 3, they should be affordable. This is my A3. Because that's what has undermined some of the public finances in many African countries, including Nigeria. In trying to make things affordable, you have very wasteful subsidies. But then subsidies end up saving actually those who don't need the subsidies. So that is my third A. And then my last A is accountability. You must account for the resources. Remember the 4 A's: availability, accessibility, affordability, and accountability. It is so important for the public finances to generate the confidence we need among our people. Now, the third point about our resources, which I want to leave with you, is that we're not born equal. We don't have the same chances in life. We don't have the same opportunities. So we must be able to carve out resources which protect the vulnerable, which protect those who need safety nets. That's what subsidies should do. Any system which does not provide for the weakest in society will not be unfair, it will not be sustainable, and it will fail. And then the other point, which I think was mentioned effectively this morning, it should be able to pull the risks, because the government cannot do everything. States cannot do everything. But between federal government, state governments, communities, municipalities, companies, individuals, we can pull risks together. That is what we call the National Health Insurance Scheme. It is not a technical format. It is about how do you put all these risks together. And my last point about a viable system which we should seek to build, you have to save for the rainy day. There will be a day when the resources are scarce. Maybe oil prices have gone down, maybe they have some drought or things like that. So for me, Mohammed, colleagues, Senator, these are what I call the iron rules, the cardinal rules of public finance. If you get this right, I think we need less and less of foreign aid, which was the question. And I will urge you, as you discuss these issues, if you can zero around these issues, I think we can get it right. Sorry to intervene. I think Mohammed had answered the question very well. Thank you.
Thank you. So, Dr. Donald, thank you for the 4 A's. My next question, 4 A's. Yes, 4 A's. My next question actually speaks to one of the A's, affordability. In the course of this week, we've seen how the poor and the vulnerable have struggled with health insurance. Currently, about 20 million are insured. My next question will be to Dr. Harry Banigo. From a legislative point of view, if we want to increase coverage from 20 million that it is now to say 60 million, 100 million, we have a huge funding gap. While we acknowledge that over the last few years, there has been an increase to funding in the health sector, but, there's still a huge funding gap that we still need to address. And like Oliver Twist, the health sector needs more. What are your thoughts in terms of inching closer to the declaration, the Abuja declaration of 15% of budget to healthcare, or perhaps increasing BHCPF allocation from 1% to 2%?
Thank you very much. I did mention that, thank you for your question, that we already have a bill in place which proposes increasing the basic healthcare provision fund from the consolidated reserve fund, which is presently at 1%, to 2%, and in that to have a dedicated account for immunization that will take care of all the issues around cold chain provision of vaccines, and all the logistics around it. and it will be a dedicated fund. Now, this is where I say I need everybody to come on board this, because it's something that will go for public hearing, and it will need the cooperation of the levels of civil society and various levels of government. I think that this would substantially increase funding for health. But at the same time, we have in our budget an infrastructure fund for health, which is coming up also for the first time. That infrastructure fund for health is very necessary because it covers areas like power provision. We had a bill which puts across at least 50% subsidy on power for the public hospitals, going from the fund that is available for such activities. And we believe that all this can provide additional sources of funding, which we definitely need in the health sector. Also, we agree that a lot of health activities are going on in the private sector. Very many of our clientele, our communities are actually attending private health institutions. So we cannot leave them out. We need to bring them and let them be part of, tell us what they are doing and see how we can enable them and how we can give them the enabling environment to do what they are doing and be able to provide those additional health care that our people need. And also we mentioned health taxes, which we need a framework for it. We need to have evidence-based for that before we can be able to proceed with that. Because those things have, there are pluses and minuses to them. But I do believe that if we have enough evidence-based information and we take the required framework, we can develop a legislation that would work for everybody. And we also, the minister in his discussion mentioned the diaspora. We need to invite the diaspora to come and take insurance for their constituents. Because when I started mine, I did it, I thought, this must be an innovation. And it was an innovation because I don't think any other legislator has done it as far as I know, and has succeeded. Because it was a painstaking process. We actually took time to enroll our members, our constituents. We took time to get them before they got their cards, their NHIA cards, and before they could access health centers close to them that are functional. And we had to train the health workers in those health facilities and also train the HMOs and all that and all that. And then for them to be able to access this. And if the health center cannot, they have the opportunity to be referred to the next comprehensive health center or the general hospital. And so if our diaspora is, and I did this because I noticed that I was always getting calls. Every time I get messages, send me money, my child is having an operation, my daughter is in delivery, my grandfather is sick, and all those things. And I thought, wow, why don't we just try and see how we can cover these people? And these are vulnerable people. So I would encourage that there are still so many other sources that we can expand our the funds that we have available for health. And we need to also sometimes think outside the box. And if we do that, we'll be able to, and also, very importantly, that these funds must be used efficiently. We cannot overemphasize the accountability framework that must go with it. And we need to use, whether it is technology, data, whatever it is, we need to use to follow up this money, to follow up the funds, make sure that they get used for what they are meant to be used for, so that we avoid wastages, we avoid these several vertical things happening when they could just be done in one block. And that way, we will be able to achieve close to what we want to achieve. Not maybe 15%, but we'll be inching closer to it as time goes on. But I know that this government under our President, His Excellency, President Tinubu, GCFR, is committed to ensuring that domestic resources is activated, is mobilized, and it's sustainable, and is willing to bring in funds, even outside, like when he brought in the additional funds for HIV intervention, which now added to the 2025 health budget, was a plus. So these are the things that we have the political will, and I believe that we will get there. I have confidence in that.
All right. Thank you. We've spoken quite a lot, quite a bit around this. I still have a few questions, but I also recognize we are out of time. But because it's a dialogue, I would like to give the audience one opportunity to ask my distinguished panelists one question, such that we can now close the panel session. One question, please. The lady in white, please. We can only take one question. Please, let's make it brief as well.
Thank you very much. My question is actually for the WHO regional head. As a cardiologist, you've seen a lot of things when it comes to non-communicable disease. Straight up. That's what the region is suffering from now. And let's move from that. Nobody can treat anything that has to do with non-communicable diseases without taking antibiotics and all. This is where we have resistance in the region. Despite progress, we still have weakness when it comes to our One Health approach. So I will want you to just address that, the strategy you'll be using to harness the region One Health approach and ensure that our borderlines are safe and we can respond to any outbreak real time. Thank you very much.
Yeah, thank you. You've been cutting. I didn't get the entire question. I heard about cardiology, the outbreaks, and antimicrobial resistance. So I'll try to. One Health approach. Thank you. Yes. No, thank you. About One Health approach, I think I touched a little bit, but let me put it this way. Can you hear me better? I touched a little bit on One Health approach in the beginning there, and I gave an example of our outbreaks. Most of these diseases, they are zoonotics when you talk of outbreaks. You look on Marburg, you look on Mpox, you look at Ebola, you look others which have happened outside our continent, SARS, COVID itself, etc. There is this component of they are coming from the animals and then coming to human beings. I'll give you an example of Marburg, which happened in East Africa recently. In October, it happened in Rwanda, then early February, it happened in Tanzania. It was simple farmers who went to farm near the caves, and their beds there. This is where the transmission came up. And actually, even yesterday, I was discussing with Professor Pate. He told me about an incident which they found some antibodies in the beds. So when we talk of One Health approach, quickly here, how many specialties you see? There is a veterinary part, there is a human part. So we need to approach these outbreaks in that manner. It's a multi-sectorial, and you can touch in most of other diseases. It has to be a multi-sectorial approach. The other thing which, if I heard you properly, is on antimicrobial resistance. It's a big issue in our continent. It's only 40% of the member states which have got a database. So if you ask me today, even how impactful is antimicrobial resistance to our continent, it's hard to say. So one of the things which WHO is going to do is to, because we are not going to any member state to substitute Ministry of Health. No, we are complementing what the ministries are doing. We need to get the database. We need to help the countries with expertise to establish it, because that's the time we are going to know the impact. And then it all goes back to education and everything. Madam, when you got a prescription of 7 days of antibiotic, and most of us, we usually don't finish, where do you dispose those antibiotics? Do they go to the water sources? We know what happens with our animals nowadays, all the antibiotics given. So it's a very wide thing, and we as a normative organ, a technical organ, we are going to work with member states. We have 47, we are in every country which is a member state. And despite the financial crisis, one thing which we have preserved, we are not going to close down any of our offices, which will help us. What we are doing now to finish because of time, we are trying to map our WRs, our representatives, their key questions. We have asked them, they are feeding us. Because if we want to move forward, we have to know what is Nigeria doing, what is Ghana doing, what is doing. Because we can collectively bring the expertise within South-to-South collaboration.
Sure.
But end of the day, really, I would like to underscore the importance of primary health care, the insurance. That's where we can cover all the vulnerables. Thank you. I'm not sure if I've answered your question collectively.
All right. Yes, go ahead, sir.
I'll just put something that didn't come up in the panel and hasn't come up all day, but which is, I think, very important. Minister of Finance mentioned health is key to human capital. It's a cause and a consequence of human capital accumulation. As we accumulate more human capital, as we get prosperous, we invest more in health, we invest health, we build human capital. But there's a dimension that I also wanted to bring, which is the dimension of social capital. Health can contribute to building social capital. So in our country, we are challenged. There are lots of divisions, all kinds of requirements for healing. By coming together to address the health needs of our population, in fact, we can forge improved social capital, and that itself can help us grow even further. I mean, Donald here is from Rwanda. I think one of Rwanda's secret is not necessarily only the technical part, but the pool of social capital that they had in the post-conflict period helped address those needs. Because then you have to look at the poor and vulnerable and saying, let me look not only at myself, but what is it good for society? What are the commons and how do we preserve the commons? And public health spend is in fact for the commons. Because if you prevent TB, you deal with HIV, you deal with malaria, you deal with antimicrobial resistance, you deal with pandemic preparedness, it's for the commons. You deal with environment, it's for the commons. So there's that dimension. So the financing has dividends in human capital, but I think it also helps us build social capital. That's it. Thank you.
Fantastic close to our panel conversation. The coordinating minister, has just expressed how health can help to build social capital. So help me to appreciate our distinguished panelists for the conversation. The conversation continues.
Thank you very much. Honorable Minister, traditionally after a panel, we do take group photographs down here. If you could just kindly join the Honorable... Oh, Honorable Minister, distinguished Senator, I've been asked by the gentlemen of the press that you would have better shots on stage, actually. I think, please. The DGNHIA will join them, and the Permanent Secretary, Federal Ministry of Health. Ma'am, could you please also join the panelists? I invited her.